grateful for all the other speakers and all the people that couldn't join us this evening, but really wanted to be here. So I have the pleasure this evening of introducing Prof. Kirsten Helvig, who's the Senior Consultant in the Department of Neurology at St. Joseph Hospital in Bochum, Germany. She was just telling us how lovely it is there. Dr. Helvig attended medical school at the Ruhr University in Germany and has obviously a special therapeutic aspect, holds a postdoctoral lecture qualification in special therapeutic aspects in patients with multiple sclerosis. So we are very lucky to have her with us this evening. Her scientific interest is mainly clinical, with a special interest in the field of MS and family planning. So I think in terms of expertise, we couldn't have had a better person to join us this evening and give us the lowdown. So Prof. Helvig, over to you.
So thank you. I have to do the screen sharing. Okay, can you see my presentation? Can you see it? Yeah, okay.
Yes, we can, yeah.
Okay, great. So I will start and give a presentation, and hopefully we have enough time, I think, also for questions. And thank you very much for inviting me. I did not only attend medical school in Germany, I also attended medical school in South Africa. I spent my final year of medical school at the medical school Stellenbosch in the Tygerberg Hospital. And I would like to talk, so here, first of all, you see my conflicts of interest. And why is it important to talk about this family planning topic in multiple sclerosis? Of course, MS affects more women than men, and interestingly, the numbers of women affected by multiple sclerosis is increasing. And also, MS is a disease of young patients. So the mean age when people are diagnosed with multiple sclerosis is 30. And this is, of course, an age where family planning is an important topic. And during this talk, I would like at least to touch the following questions. I built up a large pregnancy registry in Germany, and I also advise many patients. I don't know, today I got 15 emails from patients to any topics concerning the pregnancy planning questions. And I think these are the most important I picked out, at least for an overview and a 20 or 15-minute talk. And I can give you short answers, which are mostly positive. So can I use, but I will give you a longer answer in the following slides. Can I use hormones to get pregnant? Yes. You can have a baby. The disease will not negatively affect the outcome. You can deliver as you want to. You can, this was the not the no. So there's no negative effect, long-term effect of the disease on the course of multiple sclerosis, on progression or disability. How to deal with the treatment, I couldn't find, and this is a little bit more complicated. I will shortly touch on this. And women with MS also can breastfeed. So this is the very short answer to many questions. And here a little bit more detailed. So coming to the question, fertility is, so we have very, very few studies investigating if fertility is influenced by multiple sclerosis, but we think most likely not. And it's also not influenced by the current MS medications we use. What we know in this, you see here in this graph, a couple of studies investigating the relapse risk after hormonal stimulation. So if you cannot get a baby naturally and need hormones, and then the risk if the woman does not get pregnant for relapses might be increased. At least 5 studies have found this. And so my advice here is when women are stable on their MS medication, that they stay on their MS medication during the hormonal stimulation. But this also, if you have their specific questions, you have to discuss this with your neurologist. coming to the, but this is about 10 to 15%, and this is also age dependent, are affected by fertility issues of the normal populations, and this is obviously also true for MS patients. But the most normal situation is that you decide to become pregnant, and you will become pregnant after a couple of months. And some general recommendations are here at this slide. I think it's really important to talk to your doctor that family planning is an issue. The second, and early, if you can, really early, even if you say, okay, not now, but perhaps in 5 years, and talk to your neurologist. If you can, and this is of course dependent also on the availability of drugs, but choose a pregnancy compatible. DMT is the abbreviation for disease modifying treatments. I mean here every immune treatment for MS. And if you still have family planning wishes, choose a pregnancy compatible DMT. A lot of patients ask about the genetic risk, and this is low if one parent has MS. MS is not a hereditary disease. The risk for the children, if one parent has multiple sclerosis, is low and lies between 3 and 5%. The risk for pregnancy complications is not increased due to the disease, and therefore the pregnancy is not a risk pregnancy. And I think my most important recommendation is really, if you then have an acute wish to have children and to plan a pregnancy, is to see your neurologist and get a counseling. How is the best approach short term, what to do with the drugs, and then also plan the postpartum phase. And I also recommend the intake of folic acid even before you get pregnant, in the phase of planning a pregnancy. And here you see that, so most of the studies really show that multiple sclerosis has no significant impact on conception, pregnancy outcomes, and cause of pregnancy, pregnancy outcomes, and fetal development. And this is shown in this 2 parts here with the mother and the baby. So the outcomes of pregnancies are similar to healthy women. Premature birth, stillbirth, malformations, spontaneous abortions, it's very most likely not influenced by the disease itself. But we are still doing, of course, for newer drugs, there are still data missing. So this is true if you have multiple sclerosis and do not take any drugs, but it's also true for some drugs, but I will touch the drugs later. I would like to start with some other so this we are already good news for the baby's health and general cause of pregnancy, but a lot of women know, and there were older data showing that the relapse rate is increasing after birth. And this, you see this here in this graph. So the black graph is an older study published 20 years ago, showing that the relapse risk is decreasing. So this reddish block here is pregnancy. So this first trimester, second trimester, third trimester, relapse rate is decreasing during pregnancy, and then to increase then after birth. During pregnancy, according to this older study, 80% were relapse-free during pregnancy. And here, about in the first half year postpartum, 30% had a relapse. And the red graph is new data from Kaiser Permanente. It's health insurance in the US. And what you see, the relapse risk is much lower. It's still decreasing during pregnancy. Nearly zero, less than 10% have a relapse during pregnancy. But then there is not anymore, we do not see a postpartum rebound anymore. So this is at least true for mild to moderate multiple sclerosis. It could be different for highly active MS, and I touched this later. And in the whole postpartum year, only like 26% had a relapse. coming to the drugs. Just going back, so most of these women here were treated with glatiramer acetate or interferon beta. And these are the drugs where we really have the largest body of evidence that they are not harmful for the babies. We got in Europe, I learned that label update is awaited in South Africa, but we got a label update by the EMA in September. And I recommend to stop, or many women like the idea to stop the injections during pregnancy, and most women do so. But if you have a very active disease, well controlled under both drugs, it would be even okay to continue the drugs during pregnancy. And the interferons are also the first drug, at least in Europe, approved during breastfeeding. And both drugs are large molecules which are unlikely to enter the breast milk, and therefore unlikely to be ingested by the baby if it drinks the milk. The problem is, of course, I'm aware that it can be complicated with some of perhaps also the newer drugs in South Africa. But the problem of new drugs is and pregnancy is that we do not have a lot of pregnancies exposed to these drugs, and it takes 30 years to understand the toxicity, to the reproductive toxicity of a drug a little bit better. And what we do in the counseling is really to find the best risk benefit for the mom, but also for the baby concerning relapses, and of course the safety for the baby. And as you saw in the first slide, it's okay for the injectables, but it might be if you are highly active and are on drugs like natalizumab or fingolimod, it might be a problem to stop them, and some women have relapses. And here you see a publication from last year from an Austrian group who was showing a little bit the same. Here in patients who were not on a DMT, this olive green graph, so there was no rebound postpartum, but if on highly active or highly efficient DMTs, there was still an increase of the risk postpartum, and also an increase in the risk of disability. Coming to two tables with drugs here, and I summarized a little bit what is known about the drugs and exposure during pregnancy. And as I said before, and you see this here, if we have a lot of pregnancy, we can evaluate the safety profile of a drug. And we do have a lot of pregnancies for interferon and Copaxone, 2,500, but most of them only exposed during the first trimester, meaning women recognize pregnancy. This is mostly between gestation week 5 and 6, and they stop their drugs, and then they continue pregnancy without drugs. Only very much fewer pregnancies are really exposed during the entire pregnancy. But these are really the drugs with the best experience. DMF, Tecfidera, is okay, but only 300 cases. In Germany, most women stop it, or everybody stops it when they become aware of pregnancy. I do not really recommend to stop it before pregnancy. It's different with fingolimod. This is, and I think that fingolimod is available in South Africa. So fingolimod is tricky. There can be severe relapses if you stop the drug. I do not have the best solution for it. What to do? Another option could be to go on other drugs, on other monoclonal antibodies, perhaps. And I think, but if you have the choice, then, and the MS is really active, I think it's rather advisable if you have the choice between fingolimod and natalizumab, perhaps to choose natalizumab if the disease is very active, but this is dependent on many factors. The recommendation is to discontinue fingolimod 2 months prior to conception, and teriflunomide has to be stopped and washed out before pregnancy. And oh my God, I have one slide missing, my monoclonal antibody slide. So I tell you what is on there. So for natalizumab, there are a couple of pregnancies available, 500. And there are also data available continuing natalizumab during pregnancy. What I personally do, I extend the infusion intervals during pregnancy, and other good options, ocrelizumab, I think it's only available by a case-by-case decision, perhaps Mavenclad-2 in South Africa. If you have drugs with a longer effect, but without taking the drug, this can be beneficial for a pregnancy. And this could also be true for rituximab, another CD20 antibody. I don't know if you can, so this, even if you could not get one of the others, this could also be a good option if the MS is really highly active. And that's, I think, yeah, these are good options if you have very aggressive MS, but only few MS cases are really very aggressive. And for most of the data, for most of the pregnancy outcomes, we do not have really a signal. Fingolimod should be stopped. So we recently got an EMA warning. Steroids during the first trimester could be teratogenic and induce clefts. Other than that, if there was a risk, because I mean, we only have a couple of hundred pregnancies except for the interferons or injectables. The risk is really small, but we still need a couple of years. But I think knowledge is increasing, and we will be able to also to handle aggressive MS cases, and we will know much more in the future. For fathers, there is no limitation except for cladribine. Both sexes, men and women, should not become pregnant or create a pregnancy 6 months after the last dose. And in the US, there's also a washout for teriflunomide. Coming to the last part, okay, the baby is born. You can deliver as you want to. You can have anesthesia as you want to. This is the type of delivery, and the type of anesthesia is not influencing the risk of postpartum relapses. And then there's the question what to do to breastfeed or not to breastfeed. And there are a lot of emotions in this breastfeeding topic, but breastfeeding is healthy and has multiple health benefits for the baby and for the women, so it's generally recommended. And my personal opinion is that women should not be discouraged to breastfeed if they want to breastfeed. So it's really important. If somebody does not want to breastfeed, breastfeeding will not work. But if you want to breastfeed, it's not harmful. And this you see here. And let me explain you. It's a scientific graph. It's called forest plot. And everything which is here at this side of the graph, every blue dot would mean that the risk, that this study was showing an increased risk for relapses if the woman breastfed. But what you see that most of the blue dots are at the left side of the one, meaning that those who breastfed had fewer relapses. It's not totally clear if breastfeeding is perhaps even a little bit protective, but most of the studies show that breastfeeding is not harmful. So exclusive breastfeeding, these are data we have published, might be even beneficial in women with milder diseases. Women can breastfeed and if you do not breastfeed because you are afraid that the MS is breaking through, it's rather, I think, and this is changing also during the next few couple of years, it's perhaps rather possible also to breastfeed with some of the MS medications, mainly injectables, and perhaps also in the near future monoclonal antibodies. If you take, I mean, you have a lot of sun in South Africa, but if you take vitamin D, if the mother takes 6,000 units of vitamin D during the breastfeeding, this will also supply the baby. And if you do not want to breastfeed, I would advise to restart the MS treatment early after birth. And I would like to conclude. So it's important to talk about that family planning is an issue with your neurologist or the MS nurse. Choose the right medication, and really the risk for an unhealthy baby is very low, also for pregnancy complications, and also the relapse risk is low for mild and moderate MS. It could be higher in aggressive MS cases. And there it's especially important to plan a pregnancy and to counsel with your neurologist, and if it's really complicated, I really, it's also very okay for me if you write me an email. And the company, it's a company who developed these little brochures, but I think they are interesting to read and objective. So and they will come out in the next couple of weeks. So hopefully also being available in South Africa, going to the different steps of becoming pregnant or being a mother. And by this, I would like to thank you to invite me. So as I said, I spent my final year in South Africa and I really have very beautiful memories to have been there. I come to Cape Town in March and I really look forward to this. Thank you.
Thank you very much. What an interesting talk. Prof, a quick thing. We look forward to having you in South Africa, and I hope we get to meet. I hope we don't miss each other when I head to your town and you come to ours. I'm going to ask if there are any questions. If you can please submit them via the Q&A section now. Alternatively, we also have a couple of questions that we'd like to ask from our side. So I have launched a poll. If you guys can please answer those questions. I think it just gives us a bit of an idea of who our audience is and obviously what your experiences are. I'll give you guys a minute to do that. Gee whiskers, from my side, just a comment. Prof, rituximab is available in South Africa, but I mean, as a drug, but funding it is obviously quite a challenge. I'd actually be quite interested from my side to know if any patients have been successful in actually getting funding approved, because we battle with a lot of the other conditions that use rituximab. So I just wanted to let you know that it was available. Right, I see some votes are coming through. If everyone can vote. There seems to be someone typing, but I'm going to read through one of the questions that we got earlier. So I understand that there is a disease-modifying medication that is considered safe during pregnancy, and the disease seems to have a honeymoon period during pregnancy. However, I see my internet. Can you hear me, Prof?
Mm-hmm.
No, have I lost everyone again? They're load shedding back here, I think. Okay, so back to the question. There seems to be a disease-modifying medication that is considered safe to use during pregnancy, and the disease seems to have a honeymoon period. However, after breastfeeding, and should the patient not do well on Copaxone, what would be recommended disease management? Considering that some medications are immune system suppressants, and children are great for carrying all sorts of illnesses that can affect an MS patient. So I'm not sure if you have any feedback on that.
Yes, in principle, every MS drug is interfering with the immune system. So severe infections are unlikely under the injectable drugs. But if the MS is like being more active and aggressive, you might need a stronger drug, and then the risk is higher with perhaps for infections. To my personal experience, I do not see that my even with the higher effective drugs, my moms are more sick, perhaps in single cases. So I would recommend you the drug which controls your disease and which is available. I would not have a special preference.
Okay. And there was another very interesting question, which I found quite intriguing. How to deal with the fatigue of MS that generally comes with MS whilst being a mom? And I don't have MS personally, but I'm exhausted 99% of the time from my kids. So I can't imagine. And I suppose also with regards to carrying your baby, walking around, moving around, etc., I think that must be quite a challenge for some of the MS patients. So are there any specific just sort of guiding points that you can give patients who are looking at having babies?
No, I think fatigue is one of the most difficult symptoms if you are not pregnant, have a baby or not. So fatigue is really one of the most difficult MS symptoms and very hard to reduce. So to my opinion, the best way to reduce fatigue is really exercising. But of course, this is, it's a vicious circle. The energy to even start the exercising is reduced. But at the end, I think this is the only really effective measurement. Sometimes fatigue is better between. So if you have kids a little bit older and they start to bicycle or do some sports, perhaps you can combine it. Sometimes a little bit symptomatic treatment, so increasing the vitamin D levels. Vitamin D is often low in MS patients during pregnancy, and in everybody. During breastfeeding, vitamin D is low. Some people have a beneficial effect of if you substitute vitamin D. Healthy nutrition, and I think exercising are very general advices. And another advice is if you have an offer to get help from family, friends, to do a walk with the baby, or to spend some time with the baby and you can rest, you should really take this help.
Yeah, absolutely. I think that goes for parenting in general. They say it takes a village, and there's some truth to that. Okay, thank you so much, Prof. I'm now going to be handing over to Steffi, who I can see looks exceptionally nervous, and she told me earlier that she was very nervous, but she need not be. Steffi describes herself as a wife, mom, career woman, and MS warrior. She's 31 years old and was diagnosed with MS 5 years ago, and is going to share a little bit about her story. So Steffi, over to you.
Hi, thanks, Kelly. Okay, I also got a presentation which I just got to share with you guys. Just open my desktop quickly.
If I can, while you're putting it up, I've seen one question's just popped through that maybe Prof would be prepared to answer. my mother and I have both been diagnosed with MS. Does the chance of my children having MS increase since already showed in 2 generations?
I don't know the exact numbers. The highest risk you ever can get with MS is known from twin studies. It's about 25 to 30% if you are genetically identical. So it might be a little bit higher than 3%, but I cannot tell you. I would definitely say below 10%.
Okay, thanks very much. Okay, Steffi, sorry, back over to you.
No problem. Okay, so I'm guessing everyone can see my screen.
You can.
So yes, Tina, I know Tina through MS, and she asked me if I wouldn't mind coming on and chatting to you guys briefly. I was diagnosed in March 2016. Also just a quick note from my neurologist. I had Bell's palsy when I was in grade 10, so I was 16. I woke up one morning and the left side of my face was completely paralyzed. And this, I went for acupuncture to treat this, and I kind of came out with no symptoms, which was amazing. I then woke up and I had a really numb thumb, and I thought slept on it, all funny, which spread to the left-hand side of my body, which later spread to my right eye. My neurologist, he assessed the situation and everything. He didn't think that any scans would be recommended because he did nerve conduction tests and everything. So a month later, I deteriorated quite rapidly, and I was actually admitted to hospital on that Friday, so just a month later, and he actually thought I was having a stroke because I'd lost complete vision in my right eye, and I was off to an MRI scan, lumbar puncture, and obviously confirmed my diagnosis, and had a steroid infusion at the time. I had suffered optic neuritis as well. And also had something called an Utos phenomenon, which is when I was affected by heat. So any kind of heat, I was affected. I trained a lot as I was pretty much very active anyway. This was just a few days after my diagnosis, and I had the lumbar puncture, and I was kind of bedridden for a while, and it was quite traumatic. So I was very proud of myself on this day. Took a photo of it because I'd been crawling to the shower and everything days after my diagnosis. And I was a very active person. I was a workaholic. I had a lot of stress. I suffered a lot of childhood trauma. And I think my body was just shutting down. And this was a way of telling me to slow down. And something's going to give, and this was MS. So I was exercising, probably over-exercising twice a day. I was eating when I was hungry, so I wasn't getting enough calories at all. And I was just overdoing it. Work was hectic. I was traveling all the time, and my life was just pretty much go, go, go. With that being said, I decided I needed to make a change. And the first book I bought was The Wars Protocol, and I related hugely to what she had been saying, especially because she was a doctor herself, and doctors always prescribe medication, and she realized that medication was actually not going to help her. I don't know if anyone knows her story, but it's really phenomenal. So if you do have time, I would definitely read her book. And I went and sought out nutritionists, and I just went to look at my lifestyle, my sleeping. I wasn't sleeping, I wasn't eating enough food, and I definitely wasn't taking any supplements. My D3 was lacking, and that's obviously a big thing with MS as well. So for me, I took quite a natural, drastic approach. I took up swimming. I started sleeping 8 hours a day. I started taking a bit more of a relaxed approach to work. I would continue training, but not nearly to the point that I was. And I feel like I was just functioning on such like low energy levels and things that this was just the kind of injection boost I needed. And I needed to get my hormones back on track, because this is something that's also overseen, I think, in women specifically. And I, over a month, 2 month period, I noticed huge changes in my life. I had so much energy. I was a lot more stress-free. And I continued to take the supplements, and I continued to just like introduce this lifestyle. Although it was there, it was just overexerted. Sorry, it's quite a bit of reading. This is all for my own notes. Having a family was always my biggest priority. I think I wanted kids from a very young age. And it was quite devastating lying in bed, and you Google, which is the worst thing ever, and you just realize they say you should never have kids, you're going to drop your kids, you're going to do all these things, you should put Velcro on your shirts because you so like you can't hold things. And that's where I was. I couldn't hold things. I was very accidental. I was dropping things all the time. I was very clumsy. I couldn't see half the time, and this was a huge blow. And I thought, I can't have children. And that's when I thought I would take this lifestyle, and I thought, okay, well, I'm doing really well and everything's going really well, and why not try for kids? And I did, and I suffered my first miscarriage, and I suffered my second miscarriage, and then my third miscarriage. If I just flip to this, I suffered a miscarriage in July 2017, and then January 2018, and then again in July 2018. And every time I lost the heartbeat at 9 weeks. I did go backwards and forwards to my neurologist, my gynecologist. She was adamant it was MS. I went to numerous specialists, and no one could pinpoint what was wrong with me. My hormones were balanced. Everything was kind of looking great. So I sought a hormone specialist, an endocrinologist, Dr. Carmichael, and he did a series of blood work, which I would highly recommend as well, because it's just beneficial for anyone, regardless to MS or not. I had low DHEA, I had low estrogen, testosterone, insulin, white blood cells, and my brain was inflamed and stressed out. So although I was working and had more energy and everything, I was still suffering a lot of stress. And this was also brought back to the childhood trauma that I had never really dealt with. I was then told that I needed a few PRP drips, turmeric powder, DHEA, and cream, and I needed to seek out a stress reduction therapist, Dr. Simon Whitehead. I did this. I was very desperate, and I then, a couple of months later, fell pregnant. It was obviously very nerve-wracking, and it was I just thought I was going to lose this baby again at 9 weeks. I was taking prenatal vitamins from the start, and I continued. I'm still on them, as I'm still nursing my 30-week-old baby, and I have been since he was born. I actually feel superhuman again, as I put it. During the pregnancy, my MS symptoms completely fell away. It was like I never had MS. So I continued to train, I continued to eat, I continued to sleep. I think I trained up until the day before my son was born. There was just no excuse. It was just my only way of dealing. And it was so amazing, because usually when I trained, that's the worst time. My symptoms would come back with vengeance, because I'm hot, I'm exercising, my hand would go numb, I couldn't see, and it was really frustrating. And when I was pregnant, there was nothing. I was very nervous that after my pregnancy that it was going to come back with vengeance. It's kind of did, because you have to understand, you're getting maybe 2 hours of sleep a night. Your body, I mean, having a newborn baby is quite hectic, and breastfeeding, as you all know. And the first week I was on minimal sleep. I run my own business, so I was also working at the time. It was very hectic, and my MS came screaming back, and it was a very scary time. With that being said, I had a very strong support system, and at every given opportunity, I tried to sleep, I tried to rest, I tried to just recuperate myself. And to this day, my son's 30 weeks now. He was born on the 4th of July. He came at 36 weeks. He was cesarean section. I did want a natural birth, but he was completely breached. And I had 1 centimeter of amniotic fluid left, and we had to deliver him. I had an epidural. I was fine. He latched on probably 15 minutes after I gave birth. And I have been able to produce milk as well, which was a big thing. I eat copious amounts of food. I continue to take my vitamins. Like I said, I'm still taking my prenatal vitamins. So that's got all your fish oils. It's got all your D3. It's got your folic acid. It's everything. And I would recommend anyone takes that. And Aiden was born healthy. He didn't have to go into ICU or anything. He was born with a PUJ, which I don't think is anything related to MS. And it was a pretty amazing pregnancy. I didn't have any issues, and I just continued as normal. And just to touch on motherhood and the future, again, I was very despondent to start a family. I was told not to. I could never do it. It's not possible. You can't breastfeed. But I think it's all a mental thing. I know I've got mild to moderate MS, but I sit here today, and usually my symptoms are the worst in the evenings. I'm tired, I'm run down, everything's a bit hectic, and I'm fine. Like, I'm really nervous as well, and usually my hand would flare up, my eye would flare up, and I'm sitting here and I'm fine. And it may sound ridiculous, but read the WARS protocol. But I'm telling you now, nutrition, exercise, sleep, no matter how tired you are and stuff, just try and do that 30-minute walk. Just try and just do it. I walk Aiden in the pram every day. It's just try and lead a bit more of an active lifestyle. And you'll see huge changes in your energy levels, in your daily life, in everything you do. And I would really like to have another baby, and it's probably something we're going to look into. But for now, I'm still kept very busy. And yeah, I would recommend, these are just a few things I would recommend. I have millions of blogs and podcasts and things that I would recommend to you guys. But the 3 books I would have you read, a big person I listen to is Gabor Mate. He's actually just looked into the realms of addiction. Everyone's addicted to something. It's not alcohol, drugs, or anything. And he looks into childhood trauma. In the first chapter of his book, he looks at an MS patient and where they've come from, and kind of try to stem where this comes from, why we get MS, what is the hidden, agenda for it. And he's got some really cool insights into autoimmune diseases. And he was very inspirational. He's also inspirational with raising kids. So his podcasts are just amazing. And looking at children and everything. So yeah, that's me. I don't know. Thanks for listening.
Thanks, Steffi. Firstly, thanks so much for sharing your story. I'm surprised that you're still standing after that emotional. The miscarriages, wow, it's just, as a mom, I think my heart breaks a little bit. But you've got such a beautiful little boy now, and thanks for giving us those insights. I wanted to know, you know, from a mental perspective, has you know, dealing with, I suppose, chronic illness in any way, you've obviously, was that a determining factor? I can see my internet's going again.
Yeah.
Was that at all a sort of deterrent in when thinking about having children? You know, the kind of notion that you might not be around for them.
Sorry, Kelly, I think I've lost you.
Sorry, I'm not sure if you guys can hear me again. I'm back. I think the electricity has just come back on now because I hear the generator switched off. Are you guys there? Sorry.
No problem.
Are you still there? Sorry,
Yes.
guys. I think our electricity, I see that our lights went off and I think our generator switched back off now. So I think the electricity is back. I'm not sure if you guys can still hear me.
Yeah.
Can you?
Yeah.
Yeah. Okay. So sorry, what I was asking was just the notion of being, you know, chronically ill. How has that impacted you as a mom from a psychological perspective? Because it's quite a bit to obviously deal with. And, you know, what have you found? I know you said exercise, etc., but how much has that impacted you in the decision-making process?
I would say not really. I don't really see it as this big chronic illness and it's going to impair my judgment. Okay, maybe I had a few of those moments in the early hours of the morning with Aiden, but I would say that it sounds quite funny, but I've actually found MS to be a little bit of a blessing in disguise. It sounds ridiculous, but I think it's actually helped me, and it's helped me realize that I need to calm down and slow down. And I don't think, I haven't taken into consideration that I have a chronic illness and it's gonna, you know, jeopardize my parenting or anything at all. And yeah, I think I'm quite confident in the person I am now. So I think parenting has also just been the best thing that's ever happened to me. So yeah, it's just all very positive. I don't know if that answers your question.
It definitely does. I think that's exactly what I was hoping to hear. Okay, thanks. So what I'm going to do is I'm going to hand over now to Tina. If you could just give me one. All right, so Tina's got a very different story. And thanks, Tina. I must just say thank you so much. For those who don't know, Tina's our Rare Voices ambassador and has 4 MS and has been really, really helpful and is just really enthusiastic. And we're very grateful to have her on board, helping us sort of understand the MS plight a little bit better. And Tina describes herself as a wife, mom, career woman, and MS warrior. And she's 45 years old. Maybe I shouldn't have said that, but sorry. And has been living with MS now for 15 years. But she's going to give us a little bit of a diverse view on what to do when things don't necessarily turn out the way that you had necessarily expected with regards to being a mom.
Good evening. Thank you very much, Kelly, Professor Kirsten, and Steffi. So beautiful to see you with your little one. Very inspirational. So thank you. I think it's interesting. I'm actually really pleased that Steffi was on tonight because I'm actually almost to some extent, in many ways, in some elements, the exact opposite to Steffi. I was very much, when I was diagnosed, I went on to the first line treatment, the beta interferons. I wasn't well. And it was about 2 or 3 years on the interferons when I decided to fall pregnant. And back then, which now we're talking, so that was like 12 or 13 years ago, the advice back then was, it was with a different neurologist, but the advice back then was to go off and then start the journey to have children, which is what I did, and not on medication. And within a 3-year journey, 3.5 year journey, it was unfortunate that I suffered 7 miscarriages. So Steffi also actually at 9 weeks. The latest I carried was until 11 weeks, and it was about 4 of those 7 pregnancies were through fertility, and no problem in conceiving. It just seemed that I couldn't carry. So it was at my last miscarriage when we had decided then to go surrogacy. Really wanted to have children. I knew, unfortunately, during that 3-year period, every time I suffered a miscarriage, I had a very large onset of MS flare-up. So it was Solumedrol, corticosteroids every single time. So really not particularly healthy or particularly nice, as well as dealing with the emotional trauma of that. So at the time, my husband had decided we would look for a surrogate. And actually a year before we went surrogacy, we had gone through the correct channels to find a surrogate through, there's a very strict legislation in South Africa, it's excellent, that is able to make sure that they call them intended parents, and the surrogates are matched appropriately, and all the legal and paperwork is done beforehand. I won't dwell on that process. I'll dwell on the fact that I then, when we decided that we would go surrogacy with my last miscarriage, it was literally the day after we got the phone call from the social worker to say your surrogate is now ready. So I'll never ever forget that moment. And when I met her, to be frank, I'm sure that I saw a halo around her head, because she espoused what I couldn't at that time be, to carry children. We today are still extremely good friends. She has 2 boys of her own, and I have my 2 boys now from the same surrogate. So I have a 4-year-old boy, which is why you saw me leaving the room and coming back, perhaps, and leaving and coming back, because he wasn't too impressed that mommy was working, and a 6-year-old boy. And she carried them both for us, my husband's sperm and my egg. And it allowed me then to go back onto medication. So that was quite important for me, because I'd been off for so long and my MS had deteriorated, and I'd got to a point where things weren't looking really good. And so I had actually changed in neurologists, and then I started 5 years ago. So it was, 5.5 years ago, just before my 6-year-old was born, I started with the natalizumab. And what that allowed me to do is for me it allowed me to be as strong as I could. It allowed me to stop having my MS flare-ups, and at the same time, my surrogate Mariska carrying the children for me. People will think about surrogacy perhaps in a very non-emotional, or perhaps strange, or very theoretical way. But there is no way to describe the relationship between a surrogate and the intended mother. Every scan, every time the baby moved, I got WhatsApps, I got calls. She would wear certain creams that she wanted me for the baby to smell. We were I was able to obviously be in theatre, both cesarean, cut my baby's umbilical cord, see them coming out of her tummy. She was in the room next door. I was in the same hospital. So I was the mother and she was the recovering patient. So we would be in this hospital the same time. She would be treated obviously from, having the baby. I would be, as the mother in the hospital, being cared for as a new mom. So the hospitals, you have to negotiate, or you don't have to negotiate, you have to discuss the process around that. And I never ever once felt robbed of not carrying my own children. I only felt extremely privileged and blessed to be able to have the miracles that arrived in my life. And they went straight onto bottle, and I was very comfortable with that. And it was something that I wanted. So perhaps everyone's different, but Professor Kirsten, I hear you. I know that it is possible. I just chose the route not to go that way because my MS at that stage, it was a little bit unpredictable. So we felt best not to mess with my neurologist with my hormones. So the kind of the process to get to having the children is completely different to Steffi. But at the end of the day, and I think this is quite nice, why the webinar allows, why the webinar has arrived, because you can see that there are multiple spectrums, and even Professor Kirsten has explained the multiple ways and the multiple discussions that you need to have, and there are multiple options. At the end of the day, one would really want to be a mom, and I think no mother should be robbed of that opportunity. And I think because there are so many options available, and ways in which that you can discuss things with your neurologists, with your family planners, with your counselors, I think that is a really, I think we live in a world where we're very fortunate to have those options. Just wanted to touch on one thing, and that was the fatigue that Kelly asked. It's really tough being a parent, A. B, it's really tough being a parent with MS. Fatigue comes with the manual, comes with the MS manual, and you figure it out. And your kids, as they grow, you teach them, and they get to learn. And it's a family journey. And so, I mean, today I actually had my infusion, so I'm not at my best tonight, and the kids running around, but the fatigue is something that is really hard to deal with. I'm not going to lie, but nothing trumps being a mom and having that beautiful privilege of bringing them into this world and seeing them grow. So I must say, I think after one, maybe we thought maybe one was enough, or I thought one was enough, but having two, real cherry on the top.
Wow, thanks, Tina. I mean, really just so interesting, and I just, such a different perspective, but I think what you said is 100% accurate, that this is not an exact science, that it doesn't necessarily have to happen. Parenting in itself is not an exact science. Different things work for different people, and I think it's just important for patients to. I'm hoping that many of them have been inspired by this to, if MS was what was holding you back, to maybe reconsider. I'm going to go through the poll results quickly. So 100% of the people on here tonight are women, which wasn't really much of a surprise. But one of the really significant things, I think, was that for 54% of respondents, MS significantly changed their plans in terms of timing and the number of children they've had. And 8% of people said MS has made them decide not to have children at all. So I'm hoping that for those patients out there specifically tonight, that hopefully that this discussion has encouraged you in some way to not necessarily change your mind, but to reconsider and and look at alternative options, and obviously maybe go back to your doctors and have a decent discussion around family planning and what can and can't be expected. And Prof. Helvig did say that obviously you should be happy to take emails and questions, etc. If anyone has any, please, you're more than welcome to email them to us and we'll forward them on to Prof. And also just to let you know that the pamphlets, etc., that Prof was referring to earlier with regards to the family planning sort of materials, the educational materials, we will make them available on our community platform on the D6. So if you're not registered, please do register so that you can get them, but we'll also circulate them via Tina as well, so that they will be available. Yeah, so thanks to everyone for joining us. I'm going to unmute our speakers for one last time, if they have any last final closing comments. Prof, I'll start with you, if there's anything to add. Prof, can you hear us?
Yes, I'm impressed. So I have by both of your stories, in Germany, surrogacy is not easy because it's not legal, and but very few, only I think in our registry we have now 3,000 moms with MS. I learned that you have 3,000 MS patients in South Africa.
Yes.
We have 200,000 in Germany and 3,000 in our in the hospital I work in. But it's but one medical point important to make it clear, because we had two histories also with the miscarriages. That's not MS related. So I think it's a chance tonight. Of course it can happen. And I also have these patients. Sometimes there are also some, I don't know the English word, if the blood clots, if there are some clotting factors missing. And so I had really a couple of patients who were put on aspirin or heparin, and then because they became pregnant quickly, and then but they lost or couldn't carry the baby. But this has to the current knowledge nothing to do with the diagnosis of MS. And I also think there are really a lot of ways to become a mom with MS, as we have seen. And every way is correct. There's not a real wrong or not wrong or right. And but so and then there are also really different perspectives. So because I counsel patients in Germany, in the whole country, so I can really only satisfy the medical level, what to do with the drugs, what to take. But I think it was great to hear the personal studies, because there's much more beside this medical level, also in lifestyle or personal decisions. But I think it was great showing that there are many ways to become a mother with MS or with any other chronic disease.
Yeah, absolutely. I agree. Thank you so much, Prof. Steffi, any closing comments from your side?
No, I just want to say thank you so much for giving me this opportunity, and I do encourage anyone, especially with MS, to become a mom any way they can, because I don't think it should limit you, whether it's surrogacy, like Tina says, or just lifestyles, or just trying to find that, I don't know, that glitch. I think it definitely is possible. And don't read everything on the internet, because that's the worst thing you can do.
Absolutely. Tina, anything from your side?
Maybe just one or two things. The first is, I think MS moms rule. I think any mom rules, but I think a mom who has a chronic condition and can still be a great mom, which you are just somehow driven to do. There is something about being an MS warrior that makes you quite I think, quite remarkable in your ability to sift through the nonsense and focus on the important things. So I think it's actually very empowering, perhaps more if you've never had a chronic condition. And last but not least, you know, Professor, it's really good to hear that you are such a specialist in your field. I would say that some of the neurologists here, are especially the specialized MS neurologists, take things like this very seriously. I have one of the women in my group on the drug that I'm at discussing family planning as we speak. And that is really encouraging, that it has become a very important topic and not to be glistened over or almost discarded. And last but not least, Steffi, I think you are going to have to do some training with me so I can increase my exercise levels.
Well, Steffi can be our resident get out of bed and get moving in the morning person.
Definitely.
We all need that, especially now in January. Well, thanks very much. I have had a squiz. There doesn't seem to be any further questions that have come through. I hope anyone who does have any questions coming through later at a later stage will send them through. I see Nicola has raised her hand. I don't know if she's done that on purpose or not. Next, I don't know if you want to pop me a message if there's something that you want to add. Nicola hates speaking in public, so I doubt that. I think it has to be a mistake. But Shane, thanks so much to everyone for joining. I hope you found this valuable. Like I said, it will be recorded. It has been recorded and we'll make it available. Prof, once again, thank you so very much for joining us this evening. Really appreciate it. It's so encouraging to see doctors that are passionate and, you know, have to just take the time to really share their knowledge and their expertise with us patients that are often so desperate for information. So we're really grateful for that. And Tina, Steffi, thank you so much for sharing your very personal stories with us. We really, really hope that we can do things like this a little bit more often. And, you know, just, you know, do what we can to help educate one another and, you know, mostly just support each other. I think this can be a lonely road, and it's sometimes nice to know that you're just not the only one out there. So thanks, everyone. Be in touch. And yeah, we'll hopefully see you again when we have our next webinar. Thanks so much, guys. Hope you have a lovely evening further.
Thank you. Thanks, Kelly. Thanks, Rare Disease South Africa.
Thank you.
Pleasure.
Thanks,
Bye-bye.
Bye.
Bye.